This is CHRIAS, Christiana Institute of Advanced Surgery and American Surgery Center. My name is Kamal Erkan. Today is October 7th, Wednesday at 4:30. In today's our educational seminar, webinar, we have new topics as we started from the beginning of this weekly event. We are doing this on a regular basis, and I have one of our surgeons who's going to be joining me, and I will, well, he's actually on the screen right now. We are going to go ahead and start introducing him, Dr. Michael Peters of CHRIAS, who's here with us. Dr. Peters, if you can please introduce yourself.
Good afternoon, Kamal. Good afternoon, everybody. I'm Dr. Peters with the Christiana Institute of Advanced Surgery.
All right, so I am just making a small change here, Dr. Peters, and it will be good to go after that. All right, so here is. Okay, and one other place. Okay, so when I do the PowerPoint, so it kind of does hide stuff. Sorry about that. All right. Am I good, Tanner, with the PowerPoint?
Oh, that's beautiful. Thank you.
All right. So today, this is our volume 6. What I mean by that is we have done so many of these events. This information we are providing is already provided before in different settings, different formats. But we try to make this a little bit easier from the patient standpoint so that we can actually make these more accessible for everyone. And we have different surgeons who's going to join us each week, and then we are going to go through different topics. And today we are going to actually talk about overview of bariatric risk complications. And Dr. Peters, who's one of the most experienced surgeons in not only in Delaware, but probably in the United States in bariatric, he's going to actually explain us what complications we may be experiencing and how often these things happens, and that's what we are gonna cover. Now, our program, we are in different places between our surgery center at American Surgery Center, but also we have a program at St. Francis, and we do also cases in other facilities as well. Now, Dr. Peters, you have different bariatric surgeons who are part of your group. If you would like to just briefly introduce them as well.
Yes, thank you, Kamal. In our practice now, we have, I think 6 surgeons total, 5 bariatric surgeons, and we perform, obviously, the gamut of bariatric surgical procedures, ranging from non-invasive gastric balloons all the way up to our duodenal switch is our largest procedure. The most common procedure we do perform is the vertical sleeve gastrectomy, and we do that as an outpatient in the surgery center. Myself, Dr. Wynn, Dr. Irgao, Dr. Singh, and Dr. Ibrahim are the bariatric surgeons in the practice, and we do have our colorectal specialist and our physician assistant, you can see here, Sydney, at the end of the screen.
Now, Dr. Peters, one of the terms that I use, the experienced bariatric surgeon. If you can tell us what makes you a better surgeon from the bariatric side?
Well,
sorry, I just want to add, like, you actually, not only you are just doing cases, but you are actually educating other surgeons. You are teaching as well. That's what I was asking.
Absolutely. I think when you seek a surgeon out, any surgeon, you want to take a look at their level of experience. And those who've done it the most often and the most frequently would be considered those with the most expertise. Our practice was the first to do laparoscopic bariatric surgery in the state. We brought that to not only the local hospitals, but to the residents and the trainees here in the state. We traveled extensively throughout the nation. and served as proctors for these procedures to other physicians to teach them about bariatric surgery and how to do that. I myself was the first surgeon in the Delaware to perform a gastric sleeve, and educated, I don't want to say hundreds, but let's call it tens of residents now, close to 100 residents on these procedures and how to do them. So if you're seeking out a bariatric surgery, you want a surgeon with that degree of experience. Otherwise, you're not getting the best procedure for yourself. So, Dr. Peters, in the last 5 sessions that I have done, we discuss the whole process from the start to the end, and how great it is that patients are able to lose weight with this surgery. This is a life-changing event for all of them. And I myself, as participating in the program with with our bariatric program at our surgery center, I have seen the results of what patients are able to see, and that's extremely rewarding. And now today we wanted to kind of see what complications they may have and how frequently these things may happen, how often they can happen. So before we get to that, at the surgery center, I was just going through some of the numbers. I think in the last 3 years only, we are over 1,000 cases at our surgery center between the bariatric cases. Now, the number is just at the surgery center, but we have probably, would it be accurate if I say between the surgeons who we have right now, lifetime total cases is more than 10,000? Absolutely. All the surgeons combined have over 10,000 case history experience. And it's very impressive that we've been able to achieve 1,000 cases in 3 years at the surgery center. I don't think there's another institution locally that can put that feather in their cap. All right. So thank you for that. And our team at ASC, there's these are including myself, but Michelle Ciano, who's the nursing director, and Jessica is one of our pre-op nurses, and Rika and James are in the business office. Now, today we are going to discuss the complications, as we said. Dr. Peters, tell us what can go wrong and what we should be expecting for those. Yeah, this presentation stems from a group, or a support group that I typically hold once a year, and people are always interested in, look, this is an operation. This involves incisions and potential bleeding and infections. I've been told that this is a safe procedure. What's the reality of it? And I like to say, well, medication has side effects, and usually those are reversible, not always. But the medication can be stopped. Surgery has complications, and a lot of those are reversible, but not all. And so, although it's a rosy picture for bariatric surgery, as it is safer than gallbladder surgery, it's safer than a hip replacement, we do need to talk about what could go wrong. So I like to divide that up into 3 locations. What could go wrong in the operating room? What are some of the early complications, which cover typically the recovery area and up to 30 days, and then some long-term issues that all patients should be aware of and that are treatable, but what people need to watch out for. Typically, the first place a surgeon worries about an issue occurring is in the operating room. And those range from things that are out of the surgeon's control, such as anesthesia, all the way up to things that the surgeon should control, like bleeding, injuries to another organ, or even an inability to complete the operation, which usually is ascribed to the patient as a complication, and then reasons that the operation may be canceled. And people don't think of that as a complication, but at the surgery center, I have informed young ladies that, congratulations, they're pregnant. And guess what? Today is not the day for your operation. At the surgery center, I haven't had this occur, but more or less in a hospital setting, I've had to tell patients that your preoperative diet that we extended to 2 weeks, we should actually have extended to 4 weeks because the liver is still too enlarged and it's not safe to proceed. And luckily, laparoscopy allows the patient to go home with 2 or 3 Band-Aids, rather than a big incision for showing a failure to do the operation. But the biggest concern we have anywhere, whether it's a hospital or the surgery center, is a bleeding complication. And because the bariatric surgeon must operate in and around the spleen, a bleeding complication from a blood vessel to the spleen is not an uncommon event. It can happen probably less than 1/4% of the time, which is a small number. But when it does happen, it's significant. The patient may need to be transferred to a hospital facility. They may need to be observed overnight. They may require a blood transfusion. And these are significant events that can delay their recovery. So we really have to watch out for that. And the most important thing is to try to have that patient lose weight preoperatively to allow us better visualization of that area and to shrink the intra-abdominal fat so we can see exactly the blood vessels that we're working on rather than simply cauterizing the area blindly.
So, Dr. Peters, I have one question here from the surgery center standpoint and for our other programs. We do have our multidisciplinary approach, and we have our care coordinators who are helping with the preparation of these patients who are about to get the surgery. Are there anything that we can do more than what we already have to help with those early diagnosis of those problems? I know that in some cases we may have iron deficiency and then we put hematology clearance. Anything else that can be done from the patient standpoint or from our side?
No, it's absolutely of the utmost importance that a patient undergo this multidisciplinary approach. We can't be specialists in everything. So the patient needs to be referred to the psychologist so that we don't miss an acute depressive disorder that should be treated medically before we have surgery. The patient should be seen by a nutritionist to reinforce those eating behaviors that need to be carried out lifelong after surgery. And this is where the weight loss begins, is before the surgery, and that makes a safer surgery. So I can't emphasize enough that everybody not only get these referrals appropriately, but the patient should utilize them as best they can and listen to the advice of those consultants.
Sure. Now, you were going through the complications, and I think the second part would be in the recovery room, which we call PACU. What can be seen in that department?
Well, the immediate post-op issues certainly do start after the operation. However, they extend for as many as 3 to 6 weeks after surgery. So within the recovery area, the anesthesia team, which is one of the multidisciplinary teams, will evaluate the patient with the surgeon. And the biggest concern is that the patient not suffer from increased levels of pain, or one of the greatest concerns is this post-operative nausea, vomiting, or PONV. A lot of patients are very sensitive to gases that they receive in the operating room. A lot of them are very sensitive to narcotic dosing. So what we try to do is minimize that exposure or eliminate it completely. We now utilize abdominal wall nerve blocks with lidocaine, which is not a narcotic. We bring supplemental oxygen to the recovery area to diminish the gas concentration in the body quickly. And a lot of the anesthesia staff will not use narcotics at all or use gas at all, and rely more on the intravenous anesthetics to control the patient. So patients have very little in their system to have that nausea, vomiting event occur. So they're much more comfortable. If it does occur, obviously we have ways around that, but it is one of the acute complications that we talk about that's very manageable, but it is included. And it occurs in less than 10% of patients overall, but it does occur.
Dr. Peters, as we are going through these, I actually talked to Michelle, our Director of Nursing at ASC, just to kind of review some of the numbers, and then I can actually prep some of my questions. So we have seen, like in the last 2.5 years, there were only 3 leaks, and then 4 blood clot, I believe. Now, One maybe issue that we kind of help with this process is our bariatric team, especially in the OR and in the PACU outside of the surgeons and the other physicians. I think our nurses, all they do 95% of the time is bariatric. And this is every day. So the question earlier too with the, like what makes someone a better surgeon, the same question, what makes the nurse a better nurse, especially in bariatric, when we repeat the same thing every day and we specialize with the team that who's also teaching us, like what I know today in bariatric is different than what I knew 6 years ago or 4 years ago. So we have that advantage, especially at our surgery center. And I do believe that we are very lucky to have that type of a model where the staffing doesn't change. It's not on per diem, so permanent nurses. And I do see the result actually on the patient satisfaction scores. Right now, in the last 12 months, with almost 125 responses, we are at 100%. So it's extremely overwhelming for us. So I'm hoping that that's kind of like what you are feeling as well.
It's certainly a commendable achievement. We've been fortunate enough now to take our vast experience where we, for lack of a better phrase, we ironed all the kinks out in the hospital systems before we brought this to a surgery center. I think if we had hypothesized that we would be doing this as an outpatient, we certainly would have been looked at as if we were crazy. But I think now this is the way things are going. It's a safer procedure in the outpatient setting. The patients have less exposure to other sick patients within the hospital system, where most of the patients are actually sicker and in need of greater care. And it's better for those patients that they have access to the nursing staff, and then that those nursing members aren't needed for us. This nursing staff that now is at the surgery center is devoted to one thing and one thing only, and as a result, they minimize these complications because their experience is so focused. This specialized team can control and look for complications that are specific to these procedures, whereas they don't have to run from a patient who's had an orthopedic procedure or a gynecologic procedure. They're focused on one thing, and they know when there's a stray from normality that the surgeon needs to be contacted immediately, and it should be dealt with. So we're lucky to have that focus team.
That's good to hear. Dr. Peters, now we are done at the surgery center. Now the patient is discharged, so there may be some other complications. If you can walk us through with those, please.
Absolutely. Patients are educated with respect to their procedure from the day they meet their, well, hopefully from the day they meet their family doctor who makes the referral, but certainly from the day they meet their surgeon, whether it's online or in person. And we want them to know that there's some things that are within the realm of normal, a little bit of nausea, maybe you've eaten too fast, you might bring something back up, that's appropriate, but a chronic feeling of nausea or daily vomiting can lead to dehydration. So for that first 30 days when people are still adjusting to their new anatomy, we want them to know that if these are complications that they're experiencing at home, they should call us right away because they can return to the surgery center and get hydration. They may need to come see us directly in the office. We can now do telehealth on the fly and talk to these patients almost in real time. If they call the office and have a complaint or an issue that needs to be addressed, we can get back to them usually within 15, 20 minutes and do something like this online and talk to them directly. Some of the more significant complications, such as bleeding and leakage, can occur after they leave the recovery room and are at home. Leakage and whatnot would be denoted by a fever at home or increasing pain. Blood clots, certainly they start in the legs typically, so leg pain that's on one side and not both. They want to watch out for that, and the patients are educated with respect to that. Wound infections are typically pretty easy to sort out. A patient who doesn't like the look of their wound can call immediately, and using the technology that each of us has in hand now with our cell phones, we can take a look at that wound even before they can make an appointment, even take a look at a wound over a weekend. I've done that frequently. One of the most significant complications that patients call about more frequently than any of these is GI issues, and often it's constipation. That's easily remedied with something over the counter And we get those calls a lot, and it's great to hear it because you know what? That one's a nice one to just check off and get off the books.
And we do have the follow-up appointments, as you mentioned, with post-op, but then because of the bariatric excellence, we do have regular standard follow-ups with our patients, 1 month, 3 months, 6 months, and then after that, each year, at least once a year, we actually do follow up with the patients, and I believe some of those we are able to help them with the early diagnosis. Now, what are some of the long-term complications, Dr. Peters?
Yeah, this is a permanent operation for the most part, and people need to realize that when we recommend that they take their vitamins daily, it actually means they need to take their vitamins daily for the rest of their life. We don't want to have them suffer from malnutrition. Malnutrition presents itself in a variety of ways. You can have poor concentration. You could have menstrual issues or fatigue. People often suffer a little bit of hair loss because their protein levels get behind. Other issues that can occur months after surgery, gallstone formation. People could get a hernia at one of the incisions. The staple line could get narrow or tight. And this all presents in different ways. So we need you to be in touch with the office on a routine basis. So after 6 months, we want to see you annually to make certain you are meeting all your milestones with respect to your nutrition, your weight loss, and your vitamin intake. It's absolutely mandatory that we get blood testing at least once a year from our office or from your family doctor to review and evaluate with you, because we don't want to have this be a non-reversible condition for you.
So, Dr. Peters, we have done so much, especially since March 16th, I'm going to say. I haven't been in that conference room almost 6 months now. Everything is through the video calls, virtual meetings. And this is almost like the new term that we are using is the integrated digital record in a way. So now what we have started doing with from our side that we can actually support our patients with the like if it's the telemedicine, in some cases there's still that in-person part that we are maybe missing a little bit, but what we can do to actually help is one of the, and with your support and with other our other surgeons' support, what we have done, I do want to kind of share this. We have our YouTube channel and the Facebook channels. They are actually doing, we are doing a lot of work there. Our goal is to make these events easily accessible to everyone, for everyone. So there are playlists. You know, this video, that today's video is going to be offline, available as number 6 here. But then there are other videos that we have already from the past that we did, or the new ones that we are doing independent from our live events. So we have so much out there. Now, what's your experience so far with the patients with telemedicine, Dr. Peters?
Well, we were early adopters of telehealth even before COVID came into play. And as a result, all the doctors here are familiar with it, they're comfortable with it, and they know how to utilize the system that they have. But patients are also enjoying it more so than I would actually think. I've seen the inside of more cars than I can appreciate. You know, that's their private office. You know, they run outside from work, they have an office visit with me, and they go get back to work. The employers like it. They don't have to take half a day off to sit in the doctor's office. The employees like it because it's a quicker and an easier way to see the doc. There are times when an in-person visit is mandatory, and obviously that can easily get straightened out with the phone calls we've done in the past. But your providers here at CHRIAS are all familiar with the system and have a great system in place to take care of you over the telehealth, and our patients are appreciating it.
Well, Dr. Peters, you had a long day. I know you guys also started much earlier than anyone else that I know. It's a different life. And I think maybe one of the sessions that we can do is what the surgeon's life look like, because most of us, we don't really appreciate as much. And I do want you to know that I do personally appreciate everything that you guys are doing for us, being available, providing the service. And also, as you said, we were early adopters, but for the approach that CHRIAS surgeons have made it easier for us to work on those challenges. And I do want to thank you. You saw patients all day long today, and then you did this event with us. So it's extremely important for us and for our patients. As you know, we are doing the daily case conferences, getting ready for these events. For me, it's always like, okay, I already have so many patients that we have seen, but then you guys are doing the actual work. So I do, again, thank you again for the all the goodness that you guys have out there for our patients. And thank you for joining us. Anything else that you would like to add before we close?
I just want to say thank you, Kamal, for your flexibility. It's been a long day for everybody. But patients who are seeking bariatric care, really reach out to us. Have your primary care physician reach out to us. We're happy to help at any time and any hour of the day.
All right. Well, thank you so much. And we'll be back next week at 3 p.m. on Wednesday for our live event. And we do have some other events coming up. Please follow us on our Facebook and YouTube channels. And this video will be available if you would like to watch this later on. Thank you again. Bye-bye.
Good afternoon, everybody. Thank you.